This presentation is going to cover some basic nutritional considerations for patients with cardiopulmonary diseases. Your objectives this week are to be able to list the diseases and conditions that constitute cardiovascular disease, identify the cardiovascular disease risk factors that are controllable versus non-controllable, and those that are predisposing. You should be able to discuss the goals of nutrition therapy for CVD, understand hypertension treatment regimens, explain the focus of nutrition therapy for patients that have had an MI and heart failure, and also to reduce the risk of another MI and heart failure. You should be able to identify the main categories of pulmonary disorders, importance of nutrition status, and describe the goal of nutrition therapy for patients with COPD, asthma, respiratory failure, and tuberculosis. In general, CVD, or cardiovascular disease, encompasses a group of diseases and conditions that affect the heart and the blood vessels. So we know about coronary heart disease, or coronary artery disease, CAD, hypertension, peripheral artery disease, heart failure, congenital heart disease, all fall in this realm. And CVD continues to be the leading cause of death for not only American men and women, but across all ethnic and racial groups as well. And though the death rates have declined, the burden of the disease is still very high. Peripheral artery disease develops when atherosclerosis in either the abdominal aorta, iliac arteries, femoral arteries, when they produce temporary insufficient blood flow in the arteries on exertion. This is also termed intermittent claudication, or when there's ischemic necrosis of the extremities leading to gangrene. Now, we know that cardiovascular disease is not just a problem in the United States, but it's the leading global cause of death, accounting for more than 17.3 million deaths per year, and expected to grow to over 23.6 million by the year 2030. It claims lives in all forms, more than cancer, all types of cancers combined. About 85.6 million Americans live with some type of cardiovascular disease, or perhaps the aftermath of stroke. So just generally, some warning signs and symptoms: chest pain, discomfort, upper body pain, discomfort in the arms, back, neck, jaw, upper stomach, shortness of breath, nausea, lightheadedness, or cold sweats. And then, of course, taking into consideration that women will most often present with atypical symptoms. Atherosclerosis is the chronic inflammation that damages our arterial walls, leading to coronary artery disease, stroke, and PAD. Begins early in life, right? It begins with our lifestyle. We also know that vitamin D deficiency has been consistently associated with elevated CRP, or C-reactive protein, and an increased risk for CVD. And vitamin D supplements are relatively inexpensive. They're simple to take. They're safe if we do not exceed the established UL, or tolerable upper intake level. And this is established by the National Academy of Sciences. Now, the development of the lesions in our coronary arteries will cause chest pain, or angina, when blood flow is partially occluded. If the blood flow to the heart is completely occluded, your patient may undergo a heart attack or a myocardial infarction, MI. Now, if there's a clot or a thrombus, then if this occurs in the cerebral artery and moves and breaks off, a stroke or a cerebral vascular accident, CVA, may occur. You can look at the risk factors for coronary artery. This is from your textbook, and you can see the traditional risk factors versus the non-traditional risk factors that lead to atherosclerosis and further atherothrombosis. Plasma lipid profile is a risk factor that has a genetic component, and those that have genetic mutations on their apolipoprotein E will actually have a higher risk of symptoms, and it can actually contribute to their CAD, because they will have a state of or a genotype that actually is altering the inflammatory effect. Elevated triglyceride levels. Someone that has chronic excessive habits of alcohol intake will have elevated triglycerides. If they're overweight or obese, if they're inactive physically, they smoke cigarettes, they're eating a lot of carbs, and over 60% of their total energy or macros. Or if they have other diseases like type 2 diabetes, chronic renal failure, nephrotic syndrome, these can contribute to elevated triglycerides. And there are actually certain drugs that will also elevate your triglycerides, corticosteroids being one of them. And cholesterol is an essential component of cell membrane. So we do need cholesterol. It's a precursor of bile acids, steroid hormones, and vitamin D. But cholesterol is not actually a lipid itself. It travels to the bloodstream in lipoprotein spheres made of lipids and proteins. And plasma lipoproteins are usually measured after fasting. We ask our patients to go get their labs in a fasting state. And we're trying to get information on their very low density lipoproteins, their low density lipoproteins, and their high density lipoproteins. Their LDLs make up 60 to 70% of the total serum cholesterol, where your HDLs make up the remainder. When LDL and HDL ratios are in balance, we call this dyslipidemia. And we're looking for, in addition to high levels of lipoprotein, we're also looking for low levels of HDL, which become a risk factor. In other words, you want your HDL levels to be over 40 if you're a male and over 50 if you're a female. Whereas for LDLs, we want these numbers to be low. There are non-modifiable risk factors. If you are older, you're male, or you have a genetic predisposition to cardiac diseases, then you are going to be at higher risk. But things that are modifiable, if you are obese, if your blood pressure is high, if you smoke cigarettes, if you have hyperglycemia, if you have low activity levels, or if you are on a diet that increases your risk for atherosclerosis. Our nutritional goals for patients with cardiovascular disease or at high risk for cardiovascular disease really is to reduce saturated and saturated fats. And we want to increase the monosaturated fats. So we try to substitute these saturated fats with maybe almonds, walnuts, pistachios, using extra virgin olive oil, liquid vegetable oils, semi-liquid margarines, and margarines that are low in trans fatty acids tend to be better choices than butter and other cooking fats that are available. Fish oils are also shown to reduce inflammation. For carbohydrates, consider using substitutes for up to 60% of your macrocarbohydrate energy. Very high carb intakes will actually decrease your HDL cholesterol level, but it can increase your serum triglyceride level. Soluble fiber, you want at least 5 to 10 grams per day and 2 to 3 grams of plant sterols or stanol esters every day. Proteins, we want to substitute animal proteins by using more plant-based proteins like legumes, dry beans, nuts, whole grains, and vegetables that do not contain saturated fats. So when you're picking an animal protein, you think of fat-free or low-fat dairy products, egg whites versus whole eggs, fish, skinless poultry, and lean cuts of beef and pork. let's take a look at the Mediterranean diet, which tends to be a really good replacement diet for patients that are at risk. Now, the Mediterranean diet really pays attention to fresh fruits and veggies, whole grains, nuts, garlic, fish, and moderation when it comes to wine. Meat and animal products are taken in only small amounts. You want to use dairy products just sparingly. And if you do use cheese, you want to choose a feta cheese. Up to 40% of the calories in the Mediterranean diet are coming from fats like extra virgin olive oil. Now, with the Mediterranean diet, you want to use up at least as many calories as you take in. So think about how much you're eating and drinking and how much physical energy or energy expended for the patient. You want to increase the amount and intensity of your physical activity to match the number of calories you take. And really the aim is for these patients to take at least 150 minutes of moderate physical activity or 75 minutes of vigorous physical activity or some type of equal combination of both every single week. So no longer are we saying, exercise 3 times a week. It has more to do with the level of intensity and how many minutes. So again, at least 150 minutes of moderate physical activity or 75 minutes of vigorous activity each week. So the Mediterranean diet, or you can also use the DASH diet, which DASH stands for the Dietary Approaches to Stop Hypertension. Either one of those eating plans will be helpful. And you are really encouraging your patient to eat nutritious foods from all the food groups. Vegetables, fiber-rich whole grains, low-fat dairy products, skinless poultry and fish that are prepared in a healthy way, so not fried, nuts, legumes, olive oil, and just eating fewer nutrient-poor foods in general. Trying to stay away from sugar-sweetened beverages, sweets, red meat, and anything with a saturated trans fat, and decreasing your sodium intake. Now, you do want to eat a variety of fresh, frozen, and canned vegetables and fruits. This is okay, but you want to do this without any high-calorie sauces added or salt added or sugars added. Eat fish at least twice a week, especially those that have high omega-3 fatty acids, so salmon being one of the most universal and easy to attain in any region that you live in. Now, for those patients that cannot eat fish or have access to sources of omega-3 fatty acids, you can also have them purchase fish oils. As far as the wine in moderation, 1 drink a day per woman and no more than 2 drinks a day per men is what is being recommended, and only for red wine. And this is because it contains a protective substance called resveratrol, which is shown to also be beneficial for these patients. But we do have to think about the drug therapies that can be used in conjunction if diet modification alone is not working. And to treat dyslipidemia, which is high lipids or high cholesterol, we use statins. But if statins aren't tolerated, there are some other medical or medicine alternatives as well. And we will revert to this typically if nutrition therapy alone is unsuccessful after 3 months' time. And you can see here the major drugs used to treat dyslipidemia and what it actually targets best. And statins will lower your LDLs and your non-HDLs, your triglycerides, while also helping to increase your HDLs, which we do want to be higher. Now we're going to move on to myocardial infarction or heart attacks, which is still the largest killer of men and women in the US, and every 20 seconds, an American is suffering a heart attack. And every minute, someone dies from a heart attack. So just to paint the picture of how important it is to work with our patients to reduce their risk of heart attack. And an MI occurs when there is sustained ischemia that causes irreversible damage to the heart muscle itself. And the purpose of our nutrition therapy after a patient has an MI is to reduce the workload of the heart. So we need to reduce sodium, saturated fats. Oftentimes we need to reduce fluid because MI will lead to congestive heart failure in the future. And we're reducing calories and controlling these according to the patient's needs. Small, frequent meals tend to be better than large meals for these patients. Large meals may raise their myocardial oxygen demand by increasing their visceral blood flow. It's also a great time to initiate education about a Mediterranean diet or the DASH diet as well. And we're doing this to prevent further coronary complications or coronary events. Omega-3 fatty acids are important here to reduce the risk of blood clots, but remember the overall benefits of omega-3. Now, we want to reduce their overall diet to decrease salt, again, saturated fats, fluids, and calories. And so what do we want to suggest then? As part of the Mediterranean diet that we talked about earlier, replacing their red meat with fish, like tuna, salmon, halibut, maybe even doing this multiple times a week. Now, they can still have red meat in small amounts, but really the goal is to replace this and reduce this completely if possible. Whole grain intake will also lower their risk for future MI. Think of rye and oats, which are especially beneficial. And it's important to avoid gluten-free diets unless the patient actually needs a gluten-free diet for celiac disease. Moving on to hypertension, which is a major risk factor for stroke, myocardial infarction, vascular disease, as well as chronic kidney disease. And nearly 1 out of 2 Americans have hypertension. And we recommend lifestyle modifications first. And when that fails, we may need to move on to medication treatment, just like with dyslipidemia. 95% of cases or more of hypertension where we don't really know what causes it, we call this essential or primary hypertension. And it could be genetics. It also can be that maybe for some reason this individual has an overactive hormonal renin, angiotensin, aldosterone system. Maybe like that feedback loop isn't working correctly. Primary hypertension is considered more of a syndrome now than a disease. This is what more recent research is telling us. But there are some major determinants of blood pressure and primary hypertension that we need to think about when we're looking at our patient holistically. What about their epigenetics or genetics, their environment, their social determinants of health? This all interacts and merges to increase their risk of hypertension. And looking at the social determinants, really, if you see if there are multiple risk factors across social determinants, environment, and genetics, epigenetics, that your patient will have an increased risk for blood pressure or hypertension. Now, secondary hypertension, in contrast, has to do with a reason for your blood pressure to be elevated based on another underlying disease, like polycystic kidney disease or Cushing's, or perhaps your patient has diabetic nephropathy, thyroid diseases, or even primary aldosteronism. These can lead to hypertension, because it affects the hormonal balance in your body, could affect the RAS, and then cause hypertension. So what's our goal? Whether it's primary or secondary hypertension, obviously if it's secondary, the primary goal first is to fix the disease or try to manage that disease. But all in all, we need to try first the lifestyle modifications. So eating a healthy diet, helping our patients to choose healthy meals and snack options to avoid more elevated blood pressure and the complications that come with hypertension. So again, plenty of fruits and vegetables, fresh preferably. And really you need to think about and talk to the dietary team which foods are going to be high in potassium, fiber, protein, and which foods are going to be lower in sodium and saturated fats. And for most people, making these changes can help keep their blood pressure low and help them protect themselves against the risk of heart disease and stroke. But for some patients, nutrition therapy alone is not going to be enough. You also have to think about your patient's BMI. Being overweight or obese does increase your risk for high blood pressure. And we use BMI or body mass index, even though body mass index is not 100% the only thing that is the indicator, right? It's not always just solely in itself accurate enough. We use in conjunction with everything else we know about our patient profile. Now, oftentimes physicians will also use waist to hip measurements to assess body fat instead, but you will need to collaborate with the healthcare team to see what is the standard for this patient, how are we going to reach a healthy weight, and help these patients include foods and physical activity that will promote a decrease in their blood pressure. So number one is really being physically active and keeping at a healthy weight. This is going to help lower your blood pressure. For these patients, the recommendation is getting at least 2 hours and 30 minutes of moderate intensity exercise every week. So moderate intensity, brisk walking, bicycling, those are moderate intensity. So that, if you break it down, is about 30 minutes a day, 5 days a week. For patients that are in the pediatric and adolescent population, we are striving for 1 hour physical activity every single day. Overall, no smoking, because smoking will raise your blood pressure, puts you at higher risk for heart attack and stroke. It does contribute to atherosclerosis. If you don't smoke, don't start. If you do smoke, we need to promote quitting and allowing our patients to understand what smoking does to the architecture of their arteries and how quitting will lower their risk for heart disease. There are some other things we want to address, limiting the amount of alcohol intake because this can also raise blood pressure. It's recommended that men should have no more than 2 alcoholic drinks per day, and women should have no more than 1 alcoholic drink per day. Now, this also will vary depending on other disease processes and how high their blood pressure is to begin with. Okay, so those are just baseline recommendations. We also have to promote good sleep hygiene. Not getting enough sleep on a regular basis is also linked to increased risk for heart disease, high blood pressure, as well as stroke. And then weight loss is the most effective means of lowering your blood pressure in totality. Weight reduction facilitates lower blood pressure even when it's only 10 to 15 pounds. This weight reduction and sodium restriction can augment the effects of antihypertensive medications. A diet for weight loss and control needs to include energy restriction and also an aerobic exercise. We'll call it a prescription. So making sure that your patient is doing something that's revving up their heart rate, like walking, swimming, jogging, etc. Now, the estimated dietary intake of salt, as we need to address sodium, is about 9 to 12 grams per day. And this though, is significantly above what the WHO, or the World Health Organization, recommends, which is less than 5 grams of salt per day. Now, most of our salt intake comes from sodium that's added during the processing of many foods. The other main source is using table salt when we eat. So those patients that will use a discretionary amount of table salt and just add it to their food. Only a small portion of dietary sodium actually comes from natural sodium content of foods. So most of the time it's from extra and exogenous sources. The U.S. National High Blood Pressure Education Program recommends lifestyle modifications for at least 3 to 6 months if you have a patient with mild to moderate hypertension. Now, eating a diet that is rich in whole grains, fruits, veggies, and low-fat dairy products, and is lower in saturated fat, can actually lower your blood pressure by up to 11 millimeters of mercury. Now, the eating plan is also known as the DASH, Dietary Approaches to Stop Hypertension, and that's what most people will remember this eating plan as. Now, if the diet is an issue, the DASH diet will actually lower your blood pressure within 2 weeks, which is really great because sometimes getting a patient to be on board with your recommendations has to do with the results that they may or may not see. So knowing that the DASH diet can change your patient's blood pressure and lower it within 2 weeks is something that you want them to know and perhaps motivate them. Now, research suggests that high intakes of vegetables like broccoli, cabbage, and cauliflower may also be especially beneficial. And we call these cruciferous vegetables. This chart can also be in this chapter of your book, and it does go over the DASH diet, not just in terms of food groups, but also you can see the daily servings, serving sizes, and some great examples. So if you are required to work with a patient requiring a DASH diet, or you see a case study perhaps, this is a good place to look for specific amounts and recommendations of foods. Now we're moving on to heart failure, which is, in simple terms, a form of cardiac decompensation. And usually what will occur is the left ventricle will start to fail, producing pulmonary congestion, but the right ventricle, when this starts to fail, is going to result in a systemic congestion, which will affect all organ systems and cause poor perfusion. When you have a patient with hypertension and hypertensive heart disease is leading to the development of further diastolic dysfunction, left ventricular hypertrophy, and furthermore, heart failure. Therefore, the treatment of hypertension can essentially prevent the further development of heart failure. And this disease, heart failure, affects about 5.7 million Americans, and about 670,000 people are diagnosed with heart failure every year. Now, there is also an expanding prevalence of heart failure after myocardial infarction. So taking care of a patient with MI will also further help deter heart failure from progressing. But we also know that there's a number of other diseases that increase the odds of heart failure: diabetes, chronic kidney disease, and overall obesity. So with all of this being said, lifestyle modification with exercise, weight loss can improve the diastolic function of your patients and help to reduce the risk of heart failure. Now that we know that heart failure is a multi-system disease, especially chronic heart failure, is associated with important comorbidities such as anemia, insulin resistance, as well as cardiac cachexia. Therefore, it's important to understand how to manage these patients from a dietary standpoint. And if the heart failure is caused by a valve failure, however, then most of these dietary measures aren't going to be that effective because the issue is in the valve itself. But if diet can contribute to the heart failure and the overall outcome of our patient, then thinking about excessive sodium can be part of the etiology. Therefore, the focus is restricting dietary sodium. So any patient that has what we call mild to moderate heart failure, they're usually on a restriction of 3,000 milligrams a day of sodium or less. But those people that are not responsive to this level or perhaps have severe heart failure, they will benefit from further restriction of 2,000 milligrams a day. Additionally, you're thinking about restricting fluids to about 1 to 2 liters, and sometimes this is also going to be even more restricted than that. And this is indicated with low serum sodium. Now, fluid requirements in heart failure really depends on the overall medical status, the use of diuretics, and other comorbidities that individual patient has, and the physician and the interdisciplinary team have to work together to figure out what is the best threshold. And thirst is a problem when you limit someone's fluid. So think about some of those simple nursing interventions that you can do to help patients that are on fluid restriction. Thinking of things like chewing gum or something else that will stimulate the production of saliva without increasing the overall fluid intake. Now, also including high fiber foods like dried peas and legumes, beans, whole grain foods, cereals, especially bran, pasta, rice, and fresh fruit can help your patients because these high fiber foods also have antioxidants that are cardioprotective. Another thing that is important is omega-3 fatty acids, as well as in the EPA form or the DHA form. Now, for patients that cannot intake enough salmon or tuna, for instance, may also benefit from overall fish oil or fish oil pills. What about with an anticoagulant like Coumadin? Now, foods high in vitamin K can actually alter the metabolism of Coumadin. So you're thinking about veggies with vitamin K like Brussels sprouts, cabbage, collard greens, kale, spinach. Now, the convenience foods and mixed dishes that contain vitamin K also have to be considered with our patients on Coumadin. And many times they are on some type of anticoagulant, being a patient that may have had an MI and now heart failure. You also want to monitor the use of multivitamins. They should be taken daily so that the protein levels can be regulated. Now, keep the amount of vitamin K from food and supplements about the same every day so that you can really start to understand how their dosage of anticoagulants is working with the amount of vitamin K that they are taking in. With our older patients, frailty is often something that comes along with heart failure, as well as sarcopenia, which is a systemic skeletal muscle disease impairing the function of respiratory muscles, so making it even more difficult to breathe. Also, early satiety, so getting full really quick, anorexia, nausea, and GI congestion, slow motility, and shortness of breath lead to cardiac cachexia. And unless we manage the micros and the macros really well, our patients may have a micro and macronutrient deficiency. Sarcopenia will lead to severe malnutrition, leading to increased rates of hospitalization and furthermore, increased rates of death. So the energy requirements are 20 to 30% greater than the basal needs because of the increased cardiac and pulmonary energy demands and the metabolic rate for patients that have a cardiac pulmonary disorder, especially heart failure. And protein and energy intake should be sufficient to maintain their body weight. And we want to use volume concentrated formulas if fluid restriction is necessary, but we have to make sure that we're meeting the increased demands of nutrient and energy requirements because this can be problematic, leading to, again, cardiac cachexia. So use caution as not to overfeed the patient as well. Again, remembering that many of these patients are on fluid restriction, so we have to adhere to that very closely. Now, cardiac patients, especially those that are undergoing cardiac cachexia, they need calorie-dense nutritional supplements, usually at 1.5 kilocalories per milliliter. And this is going to help increase their energy as well as their protein intake. And if we can't meet these patients' needs through oral supplementation, then this is when we need to consider enteral or perhaps even parenteral nutrition if enteral nutrition is not suffice or does not suffice. And when enteral nutrition is used, continuous enteral nutrition is probably going to be what's prescribed rather than bolus feedings. This is favored because it reduces myocardial oxygen consumption. Very important concept to understand. What about modifications in lifestyle? Now, it's easier, obviously, if the entire family or support system is moving along with the patient and are overall compliant. Now, dietary education should include not just the individual, but those that are preparing meals, purchasing meals, and those taking care of the patient. Including the family members is obviously an educative process. Not only is it the health of the individual with cardiac disease, but also thinking about the younger family members that are maybe now at a higher risk because their older family member has a cardiac associated disorder. We think about the community resources that we have. Organizations that offer cooking courses, think about your public libraries, community hospitals, all trying to center heart-healthy education as well as post-MI and heart failure rehab. And this will be very beneficial to those patients that are requiring ongoing medical support, but now they may need adjunctive nutrition counseling and maybe also interdisciplinary visits to help them maintain their new goal of health promotion habits and a healthy lifestyle. We also need to help educate our patients with label reading, especially those that have hypertension and cardiovascular disease, because a lot of the foods, especially the processed foods, are those types of foods that our patients may not be able to consume because they're trying to limit their dietary fat, cholesterol, and sodium. So think about what you have learned with with food labeling and how you can effectively teach your cardiac patients to discern what is a health claim versus the nutrient content claims that are on the food labels. Okay. So let's think about now heart-healthy diets specifically. Now this includes adding more fruits, more vegetables, and preferably fresh produce, whole grains. These are going to be part of the heart-healthy diet plan. And now moving on now to pulmonary disorders, we're going to talk about COPD, which is chronic obstructive pulmonary disease. And with COPD, you're going to see chronic long-term changes in overall pulmonary function. Most often, this is related to smoking, secondhand smoke exposure, environmental considerations, but also genetic plays a role in the onset of COPD. And in the early stages, you might not notice the progression, very silent, and then shortly after, you're starting to notice the first symptoms of shortness of breath, coughing, breathlessness, and wheezing and tightness in the chest. Now, all of this takes up a lot of energy. This energy required for breathing is something most of us take for granted because we don't have an issue with our breathing. But high energy demands are evident in patients with COPD just while they're normally breathing or breathing not so normally, actually. And these patients, therefore, have an increased likelihood of malnutrition because of this extra energy expenditure. And it's common to see significant weight loss from both the fat stores, but also a loss of muscle mass as well. So you're looking for patients with muscle wasting. And most of this is going to occur around the diaphragm and the respiratory muscles. So the presence of malnutrition really contributes to the patient's overall decline with COPD. So what's the goal then? The goal of nutrition therapy is to maintain respiratory muscle strength and function and to prevent and even correct the malnutrition that accompanies COPD. This malnutrition, though, is multifactorial. There are contributing factors like altered taste, because that chronic mouth breathing changes your taste buds. Also, you have excessive sputum production. Patients with COPD are very fatigued, they have anxiety, depression, and increased energy requirements, frequent infections, and the side effects of multiple medications also can contribute to their malnutrition factors. So preventing malnutrition is not only the preservation of muscle strength that's needed for pulmonary function, but also we're trying to maintain the integrity of the patient's immune system. And the first step to this is to really provide adequate nutrition. Anorexia, early satiety, nausea, vomiting, all very common in these patients as well. So energy expenditure, we know, usually elevated, but it's also going to be according to the person's baseline level of physical activity. So energy balance and nitrogen balance are going to go hand in hand. Visceral and somatic proteins can be conserved if optimal energy balance is maintained. So you may use an indirect calorimetry, which is the most accurate method of determining the patient's energy expenditure for our patients that are hospitalized hospitalized with COPD. In addition to maintaining at least 1.6 to 2.5 grams per kilogram of protein, we also have to think about the dietary sources of vitamin D, including vitamin C, E, selenium, into their diet, looking at their fat and carb ratios, and most COPD patients need to eat in small, frequent feedings because it takes so much energy to take in those large meals. And you're also thinking about sodium as well. With our patients with cystic fibrosis, nutrition is also important to their disease process. And cystic fibrosis is an autosomal recessive inherited disease of the mucus-producing exocrine glands. It's characterized by high levels of sodium and chloride. And you find these high levels in the saliva, the tears, and the sweat of patients with cystic fibrosis. You also will note that these patients will have highly viscous secretions in the pancreas, the bronchi, the bile ducts, and the small intestines, and this can lead to obstruction. CF, or cystic fibrosis, occurs in about 1 in every 3,300 births. Most of Caucasian infants, and 1 in every 15,300 in infants that are not Caucasian. So there is a connection to genetics. There are some physical signs that you might see, such as growth retardation, failure to gain weight. You will notice an abdominal protuberance. Patients will lack subcutaneous fat, and they have poor muscle tones. And these are more of the common findings. These patients will also be more at risk for frequent pulmonary infections, pancreatic insufficiency, GI malabsorption, which puts them at great nutritional risk. The average patient with cystic fibrosis lives to about 37 years old in the United States, and death most often is a result of malnutrition, bronchopneumonia, lung collapse, and cor pulmonale, which is right-sided heart failure. So now that we know that nutrition is of prime importance in the treatment of CF, think about the requirements. It's going to depend on the age of the patient and the severity of the overall disease. And this poor nutritional status becomes an issue because you think about undernutrition contributing to poor growth, pulmonary complications, and susceptibility to infection. So there is a link between intestinal inflammation and an imbalance in intestinal microbial populations, which we call dysbiosis. This occurs in patients with cystic fibrosis. The primary goal then of nutritional therapy for our patients with cystic fibrosis is to exceed the dietary reference intakes, or the DRIs. And you are going to exceed in all other nutrients by 1 to 2 times. More specifically, 1.2 to 2 times more of the DRI. And dietitians will estimate individual energy requirements based on the patient's basal metabolic rate, as well as their activity level, their lung function, and their overall fat absorption. So very individualized. But remember, 1.2 to 2 times more of DRI. Now, although sodium requirements are going to be considerably higher for our patients with CF, routine sodium supplementation isn't necessary because the average American diet already has an overabundance of sodium. So we're not really giving them any sodium supplementation. However, multivitamin supplements can be prescribed. More often than not, they will have a fat-soluble vitamin prescribed in a water miscible form, so that if fat mouse absorption is severe, it can still be taken in. Now, probiotics are also beneficial, as gut dysbiosis is associated with the GI symptoms that we talked about earlier. And probiotics can significantly reduce fecal calprotectin, which is a marker of intestinal inflammation. And this can be seen in both children and adults with cystic fibrosis. Now, since initiation of universal newborn screenings for cystic fibrosis, this is one of the diseases that we're looking for in the newborn screening that occurs at birth. Since this, we have found significant improvement because we are understanding more information earlier with our patients with cystic fibrosis. Significant improvement has occurred in nutritional status with normalization of weight in the first year of life, but we still note that height or length, so to speak, for an infant gets stunted even so, but weight is becoming more normalized. Now, pancreatic enzyme replacement therapy is an important concept for our cystic fibrosis patients, and this should be used along with all types of milk products, including the intake of breast milk. Supplemental fat or carbs may be necessary for some infants to increase that caloric density, and we're looking to have more than 20 kilocalories per ounce, which is what normal breast milk or infant formula has. So we're trying to give them more than that. Also, the introduction of solid food is about the same at the same time for patients with cystic fibrosis. Now, what about the transition from childhood to adulthood and, in adolescence? Nutritional adequacy of the diet, compliance with pancreatic enzymes, and growth patterns have to be closely monitored because as this patient gets older and more independent, we are transferring some of this independence to the patient, and so we start to wonder about compliance. So reevaluation of the patient's diet, education is all going to be important. Knowing what their baseline understanding is about their disease process and helping them to understand the recommendations to support growth and maintain nutritional status, all important aspects of their transition into independent living. What about acute respiratory failure and respiratory distress syndrome? Now, we know with the recent COVID-19 pandemic, there are many cases of acute respiratory distress and respiratory failure. The virus is highly infectious, as we've seen, and this is just one of the reasons why someone might be in acute respiratory failure. So don't forget things like pneumonia and other respiratory viruses that we knew of prior to COVID-19. But in any case, patients develop acute respiratory syndrome that could lead to multi-organ failure. And most patients with acute respiratory failure require mechanical ventilation, and therefore nutritional support will have to be transitioned into an enteral feeding or parenteral nutrition. Malnutrition impairs the recovery of these patients with respiratory failure and distress, and it will prolong the weaning from mechanical ventilation if nutritional standards are not met. Malnutrition and the method of feeding influences the overall outcome of their disease process. So, we want to maintain or replenish their nutritional status, and because a significant number of patients with pulmonary disease or respiratory failure have clinically relevant malnutrition, nurses and the healthcare team in general that are caring for these patients also have to be alert to any alterations in the nutritional status while under their care. And so nutrition support has to be initiated as soon as possible. Obviously, we have to avoid overfeeding, especially within that first week. High-calorie feedings are beneficial only after time, but that first week it's important not to overfeed. And their goals are very similar to those patients with COPD. You want high-calorie, high-protein, and moderate to high fat, and moderate carbohydrates. So like I said earlier, enteral nutrition is recommended, and early enteral nutrition following the guidelines for mechanical ventilated patients, especially in children, are going to be necessary to follow. And there are commercial formulas that are going to provide 40 to 50% of the total calories from fat. Higher caloric density formulas can also be prescribed, and they may be necessary if there's some fluid restriction for the patient. Also, the use of immune enhancing products, if you think about that, you try to bolster their immune system, but we don't really have enough evidence yet in the literature to support this, but there are some products out there. Low osmolality feedings are started very slowly, and this is to avoid gastric retention and also diarrhea. Again, continuous administration is recommended unless there's some other reason for that it's contraindicated. Most often we're doing this continuous administration to lower the energy expenditure. Because of the risk of aspiration, think about what special precautions you need to take place or to intervene with. Think about elevating the head of the bed or making sure that the tube is placed into the duodenum or the jejunum. With patients with asthma, we also are thinking about healthy diet. We're also thinking about avoiding obesity and trying to understand age-specific considerations. Now, occupational exposures and oxidative stress do play a role for adults with asthma. Overall, a healthy diet is going to be important. Now, antioxidant dietary approaches suggest that eating a variety of fruits and vegetables, whole grains, and getting enough of these natural sources of fiber are going to be key. Iron, magnesium, and phosphorus as well. Vitamin C, D, and again, omega-3 fatty acids. These are all important nutrients to emphasize with your patients with asthma. Also, think about the manipulation of the gut microbiome through prebiotic foods. This is also a strategy to influence the immunopathy of patients that have asthma. Tuberculosis has been a global health issue declared by the World Health Organization, and nearly 1/3 of the world's population is infected. Now, here in the US, we don't have as big of a issue as we do internationally. However, think about our patients that are coming in, maybe they're traveling internationally or they are part of the immigration process. When this happens, they have a higher risk of exposure, and so do you if you are taking care of these patients. Also, the prevalence of HIV and AIDS is another health threat for the immunocompromised population. So much of the same nutrition support can be initiated for both a TB patient and those that have overall immunocompromise. And what our goal is to prevent or correct weight loss and malnutrition. In addition to the multiple medications that they may be on, strict adherence to scheduled administration of these medications is what's going to resolve the disease. And it is a public health concern, and many times public health nursing is involved in this administration because compliance is often a challenge. Also think about obesity and type 2 diabetes, which are risk factors for tuberculosis as well. Now, chronic inflammation will undermine the body's immune system when you're infected with TB. Vitamin D will play a role. Low serum levels have to be corrected in patients with type 2 diabetes, and this is to protect against tuberculosis infection. Nutrition support needs to be initiated as soon as possible.